Good afternoon, and welcome to Data Retention Strategies that Facilitate Application Decommissioning Decisions, a Health Systems CIO Media Inc. event sponsored by MediQuant. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We have some interactive features that we hope you'll take advantage of during the event. One is to send in your questions and comments. You can do that at any time in the bottom right-hand corner of the screen, the Q&A box. Leave the default set to all panelists. We will take those later in the program, but again, send them in as they occur to you. And you can download the deck by using the URL on your screen. Just so you see how we're going to spend our time today, we're going to go about 35 to 40 minutes, our featured panel discussion with Andy Goodwin, CIO and HIPAA Security Officer with the Harbin Clinic, who works with Jason Lovett, who's Director of Application Services, and we've also got Pults, Chief Clinical Officer with MediQuant. So, without any further delay, we're going to jump right in. We've got a lot of great stuff to talk about today. So, Andy, I want to start off with you. Can you give us an overview of your organization and your role?
Yes. Welcome, everyone. I'm Andy Goodwin. I'm the Chief Information Officer for Harbin Clinic. And Harbin Clinic, quick overview, is a physician-owned multi-specialty group, the largest in Georgia. We have about 240-ish providers, about 1,200 employees. We're located, based out of Rome, Georgia, about a little over an hour northwest of Atlanta. We cover the northwest corner of Georgia, along with a little bit of Alabama and Tennessee. And we have roughly about 20 physical locations between our different practices. And we cover upwards of 37, 38 different specialties.
All right, very good. Jason, we heard about the organization, so you don't have to do that again if you don't want to. But about your role.
Certainly. I appreciate the opportunity to join this webinar. My name is Jason Lovett. I'm the Director of Application Services here at Harbin Clinic. In that role, we're responsible for managing the enterprise applications, a lot of emphasis on our electronic health record system, but also the other variety of systems we work with may include administrative systems like our ERP or our financial systems. We provide some support in those areas, as well as we work with some of our ancillary. As Andy mentioned, we provide services in a wide variety of specialties, but we also have ancillary services of lab, imaging, and some others that are a little bit different than the typical practices. So we provide some support in those areas too.
Excellent. Kel?
Good afternoon. I'm Kel Pults, Chief Clinical Officer at MediQuant. Been here for about 6 years, part of the executive team here at the MediQuant office. We've got 3 offices now, Brecksville, Chicago, and Columbus area. We've been in business about 20 years. MediQuant's been doing archives, started with patient accounting, and we've moved to clinical, ERP, pretty much any application that a health system needs to archive. So we're looking forward to the webinar today, and hopefully we can answer some questions.
Very good. All right, Andy, we're going to start with you. I understand, we ran into each other at Chime, and I understand you've been on quite a journey with your applications, moving things around, switching a few things from here to there, as most CIOs do over time. So you want to take me through your journey? I don't know when you want to start, how far you want to go back, but as is relevant to our conversation, some of the transitions you've made would be helpful.
Within Harbin Clinic? Yeah, I've been here about 4.5 years, and Jason's been here longer. He's going to have a little more history with Harbin, but one of the things we've been doing is working on, one, just inventorying all the systems we have out there, the one-off systems and such, and working on trying to facilitate getting those down into fewer systems. Being a multi-specialty group, it's sometimes difficult to get one solution that meets everyone's needs, so we do have some additional systems out there. But what we've done in the process, we've transitioned, prior to my arrival, they had transitioned from paper to Allscripts, and they were on Allscripts for several years, then transitioned to Athena Health, which is our current EHR, but we also have some other one-off EHRs in other individual specialties.
Mm-hmm.
So what we've looked at over the time is how do we handle all the data from these other systems, especially as we try to sunset them and keep the data accessible, and in what is the easiest way to do that. And it's interesting, we'll probably get into it more, is the many different questions that come up as you're working through the process of figuring out what to do with that data and how to archive it. And historically, and what they had done at Harbin was go with a read-only licensing model of some of these systems, which can get very expensive and sometimes not as cohesive with the point of care as you'd like. So when I got here, we started looking at how do we, one, get rid of that cost, that extra expense, but also put this data into a platform where it becomes more usable as we move forward.
Increase the usability, decrease the costs, reduce the overall number of applications, though there are limitations as to how much you can reduce it down when you've got multiple specialties who each want their own tool, because they are quite different, right?
Exactly.
They do have quite different needs. So, and that's a classic issue that everyone struggles with.
Right. And one of the things with that we're going through currently, we're working on, is Athena Health is our record of truth, if you will, but we do have other systems out there, and we're actually working through a process to try to reduce them and actually make somebody truly justify the need for a one-off, a separate, whether it's an EHR or another application they use. So we're actively trying to find ways to reduce that.
Yeah, Anthony, if I can add on that, it's been an interesting journey. In my 11 years with Harbin Clinic, we really have seen a diversity based on specialties. With our system of record being Athena, you still have the specialties that really strive for best of breed approach. And so we try and find that balance, but when we do acquire new practices, new specialties, we have seen different approaches. We've had physical therapy that joined us and had paper records. We've seen a gastroenterology department join us, and they were a one provider practice using a major EHR. We've had other practices that have been migrated that included hybrid approaches to grabbing the data and importing them into our system of record. Maybe we just needed the patient demographics, but the specialty, we didn't necessarily need all the clinical data. And so that's one of the things that we look at very closely is who's the audience for the data in the future of these legacy systems. Are we working with clinicians? Is it strictly for audit or legal discovery? And that really determines a lot of our approach to whether we migrate the data, whether we operate a view-only environment, or whether we sunset it.
Very good. Very good. All right, Andy, back to you. What were some of the decision points along the journey around data transitions, archiving, what to put where, and how cost factored in? You want to take us to a few specific decision points?
Yeah, the first one that comes to mind is obviously the transition when we went from Allscripts to Athena, and we maintained a read-only, a view-only license with Allscripts. Fairly expensive. We also, they had a custom application written at the time to help with that access, but it didn't fully replace the Allscripts view only. So as we looked at the cost we were spending on that, we said there's got to be a more economical way to make this data available. And so that's when we started down the journey with MediQuant and looking at their solution. And what was from a financial standpoint, was a pretty easy decision. The ROI was very short on that. As we looked at it, some of the questions about, well, how much data do we bring in? Do we need to bring it all, or do we just bring in a subset and then just do away with the rest, and such? And then the nice thing with the solution is one of the key points was having the clinicians having access to that historical data at the point of care. So that was critical in the need. And, you know, with the MediQuant solution, it gave us the ability to embed that right in the Athena application, where a clinician in a patient's chart could just click and instantly be connected out to that patient's archival data. So it made it very usable, easy to use. Yeah,
Andy, where were you? I'm sorry. Go ahead. We had a little technical problem.
Okay. Yeah, I was just finishing on that decision with the Allscripts data. That was a pretty easy one from a cost standpoint. It was such a savings that really drove it, and we could migrate all that clinical data in.
All right. Okay. Kel, do you want to comment a little bit on the decision points as far as the things that you've seen in your work with other clients?
Yeah, absolutely. So thanks, Anthony. So some of the decision points that clients make are, first, what to actually archive. A lot of our clients will take a look at their new EHR, whether it's, for example, Epic, Meditech, Cerner, Athena, whatever system they're going to, and the first decision they'll make is, do they want to convert any data into that system? It's not unusual to convert a small data set, whether it's some lab results, blood bank, a year provider notes as an example. So that's one of the first decisions that they'll make after they've decided on a new EHR system. The second component is really what they want to keep, or what they need to keep from multiple perspectives. So usually there are about 4 or 5 use cases that they're going to look at when they look at their legacy data. One is going to be, what does the provider need to see at the point of care? What do they need to keep for legal compliance? Do they want to keep a set of this data for analytics research? Release of information. So what do they need to be able to release out of the system per HIPAA, so that when patients request a record, they can provide that information out to them. So there are different scenarios that each client needs to actually look at. They're also looking at state, federal requirements. Different states have different rules around that. And it relates not just to clinical data, but also patient accounting data, ERP data, so HR payroll, APGL materials. There are certain requirements for retention of those, and so that is something that each individual client really needs to look at, is what are their current retention requirements? Do they need to update those? How does that apply to the applications that they're considering for archive? And then how do they reduce their footprint? So it's something they really need to think about from the very beginning. When they start looking at a new EHR, they need to start thinking about archive as soon as possible. Rather than it being an afterthought, it's best to think of it early, and then you can really lay out a good plan for not just the implementation of the new system, but how you're going to archive and decommission the legacy systems that application is going to replace.
Excellent. Excellent. All right. Next question. Let's go here. How can a well-thought-out, and Kel, I want to stick with you on this, how can a well-thought-out data retention and governance policy help CIOs handle these transitions? Any advice on getting solid policies in place? The thought here is that we don't have to figure everything out as a one-off. We've got policies in place that help us navigate this as it comes up over and over again and simplify things. We have a system, we have a process. What are your thoughts there?
So you're absolutely right. It becomes a process. It is a good time, especially as clients move to a new EHR system, to really take a look at those governance and retention policies that they have in place. Some of them we find are very outdated. They have different media in place, so they may have microfiche or paper. Some things are electronic. And so taking a look at all the requirements for those. So, for example, the scenario that Andy brought up earlier, Harbin Clinic has a lot of paper. They could have easily converted all that. I'm not going to say easily, Andy, but they could have converted all that to electronic and just said, we're going to store it all. But they probably had a good 20, 30 years worth of data in there, and with their retention requirements, they didn't need to keep it all. So instead of going to the cost of putting it all in an archive, we talked through, does it make sense to do that? In some cases, based on retention policies, whether it's behavioral, whether it's custody data, they all require different retention requirements depending on the state. You really have to look at those scenarios as individual scenarios and decide what you need to keep and what you need to get rid of. So we typically run across a couple scenarios where we've got a conflict internally. Legal would like it not to be discoverable. Once you reach the retention period, get rid of the data. The other side of the house, where we have researchers, would like to keep everything. So we kind of, we do see this a bit of a conflict and discussion that happens through that. And so those are considerations when you're deciding what needs to go into the archive and what you can actually get rid of. Now, we've got, for example, we do have an auto-assist purge within the system, but our clients, they have it as a possibility, but they don't really use it. And we really talk to them, at the very beginning is take a look at what you have now. If there are things that you can get out of the system right now, or that you can say we're not going to archive this because it's well out of retention requirements, do it before you archive, because it will save you money and it will save you time.
Excellent. Andy?
Yes. I would just add to that, simultaneously to us doing the conversion of the Allscripts data, putting it into an archive solution, we were going through our paper history. And as Kel mentioned, we had a few decades of paper history, and we actually had 3 different warehouses storing that because we had such volume. So that drove us to really define our policies around data archiving and what will we keep, because there's not a clear number out there that you have to go by. So we established our data retention policies at that time as far as how long we would keep records and the types of records and things. And as she mentioned, we looked at saying, okay, if we have these paper records, does it make sense to bring them into the archival solution, make them electronic so they're easier to access and things. And as we looked at that really didn't make sense to us. It was kind of cost prohibitive and time prohibitive. We figured at the rate we could do it, we would actually be throwing the records away before we ever got done with it. So that was a case where when you look at it, it didn't make sense to do. But we have established, as we, along with the policies, is really looking at, for us, MediQuant has become that de facto standard for any archiving. So anytime we're looking at whether it's a new acquisition or some historical data or another system we're sunsetting as we're rolling out an ERP now, that is what we compare it to, look to for planning, mapping that out, whether we move the data or what we do with it. That's the solution we're mapping it to.
All right, very good. Jason, your thoughts? Oh, please, Kel, go ahead, and then we'll go to Jason.
Yeah,
go ahead, Kel.
I was going to add one thing to what Andy was saying. I think it's really important when you're getting ready to do your archive, and this is something we do with our clients, is not everything is going to go to an archive. There are some things that you may want that is more appropriate in a data warehouse, or that you just get rid of completely. So it's important to evaluate the applications that you have to determine what is the best home for them. And sometimes it's not really a home at all. It's completely just getting rid of that data at that point. And so instead of just automatically assuming everything is going to go, to the archive, we really work with the client to say, does it make sense to go there? Does it make more sense to store it differently? Is it something you're going to access on a regular basis? What is the return on investment for you? What are the chances of you needing to access that data? That type of information is kind of important to go through when you're looking at your applications. And as much as I would love for us to archive every single thing, we can take everything, but we really want to make sure that it's the right solution for the client, not just to take everything because we can.
Makes sense. Makes sense. Very good. Jason?
Adding on to some of the thoughts there around both the paper archiving and the record retention for some of the other things that you might not migrate, some of the interesting conversations we had as we transitioned from one major EHR to another, we had the physician leadership, the benefit of our QA and risk management to help guide us in specific record types, those things that might need to be accessed on a regular basis, because you really want those things that are important for the care of the patient to be accessible without having to go through a lot of hoops. And so if you're migrating from one legacy EHR to a newer one, and some of those things that they defined as important, like allergies, those things are important even over time, that those are in the current system. And so some of those decisions had to be thought out very carefully with hand in hand with the clinicians that really understand the impact of having that data or not having that data. Now, that said, as a matter of lessons learned, we've heard much in hindsight from the clinicians that a lot of what we took the effort to migrate discreetly just doesn't map very well from one system to another. And so you're on the one hand, not being able to access it if it's not migrated and it's archived and it's offline, so to speak, with what you're using on a day-to-day basis, versus if it is migrated but it doesn't readily bubble up to the care of the patient. So you have to give a lot of critical thought to where the data will reside, both either in an archive or if it's migrated in a structured manner to your current system.
Very good. All right, Jason, I want to stick with you on the next question. What are your thoughts on training users on the new applications and making sure they know how much data has been brought over, where to find the old data, that they can keep working the way they've been working? It's very difficult when we switch to anything new. We necessarily are slowed down, right? It's just a learning curve, and it can be very painful when you're used to operating in an extremely fast-paced environment, and seconds matter, to these doctors and the visits. The seconds matter. So how do you handle the idea of bringing them up on the new application and making sure that they can navigate these things as quickly as possible, as soon as possible?
I understand. Change is difficult for all of us, and in the care of a patient, that change can slow down decision-making, can slow down the number of patients you can see. So there's definitely impact, and it's important to make sure that the clinicians are up to speed as you make these decisions, as you make these changes. We're very fortunate in working with MediQuant and the ability that we were able to integrate the archive data from Allscripts. As Andy alluded to earlier, our initial foray into archiving that was not seamless. And so when you were navigating around in Athena, our current EHR, and you wanted to see historical data, you had extra logins, and it didn't necessarily take you to the same patient in context. And so with our work with MediQuant, that little bit of seamless integration reduced the need to train these extra logins or train this extra search to find the patient in context. So a lot of really education can be simplified to the extent that the data that's archived is accessible and it's seamless and it's readily available. That said, when we talk about specific data types that are converted, it's not always straightforward for the physician to understand why am I having to go for information related to this patient's problems that are older than 3 years out to this outside system. And so we did come up with some handy cheat sheets, some references that they can look at in order to know that this is the criteria of what was brought in, migrated, and this is the criteria that may have been archived for outside and research purposes.
Excellent. Very good. All right, Andy, any thoughts there?
Yeah, I would just add what Jason was saying. One of the things, we look at the various types of data that we're bringing in and things, but also looking at the use of, and, that was a key fact for us was the clinicians, obviously, having that information, that historical data at the point of care. But we also have other uses for it. So our HIM department, who's charged with enforcing our retention policies on a lot of warehouses of data in paper form, as well as they do all the records requests and things. They have a different usage of the data. So there's a separate interface that they can come in, and they have an interface that works very well for them to do their job. So it is nice that you have multiple ways to access the data, so you can, in a sense, customize it to the need.
Very good. Kel, your thoughts?
No, I would absolutely agree. I think Andy touched on the different use cases, which is really important to think about. You involve your stakeholders when you're starting your project, involving your stakeholders, and I think even more important, which is something Harbin was very good at, is engagement by those stakeholders in the project. From the very beginning was excellent to make sure that you're not doing any rework, that you're taking into account the different use cases that you need to be able to support once you move that data. The training, for example, clinical is about 25 minutes, so the product itself is intuitive, and I think that any product that you have, we've all gotten used to using the internet and using web applications, and your expectations are for it to be intuitive, that if you didn't have any training, you could get in there and you could kind of play around with it a bit and you'd understand it. I think that expectation is absolutely what clinicians at the bedside feel as well, that they don't want to do anything that's going to take away from their time with their patients. So anything that you can reduce clicks on, which is, those types of things are things we look at when we do development. We want to reduce click times and reduce the training time for any user, regardless of what the use case is, whether it's HIM or the clinicians. We want to make sure that they've got access quickly to the data.
All right. Thank you, Kel. Very good. We are going to go over to Andy now. Andy, there's a number of vendors in this space. What advice, you obviously made your choice, what advice can you give to other CIOs about how to make a selection?
Well, there's obviously a lot of factors to look at, but I think first and foremost, you need to look at it internally first and look at what data are you looking to archive, and what types of access and how easy to access that data is. What's the criticality of that? And then as you go out and look at the market, look at the vendors out there, really ask a lot of those questions, and I'd say really ask to see that working. So the best way is if you can see it in a real world scenario rather than just a demo. But I think you really need to see that if they say it's truly integrated into your particular EHR, challenge them to show you an example of that where it is integrated. What does that integration look like? As Jason mentioned earlier about the one click to get there rather than a separate login and things, because there are some that say, yeah, it's integrated, but it launches you out to another site where you have to log in and such. So really define your parameters and then look at how close that vendor can get to what you would consider your ideal state for your use of that data.
Very good. All right, Kel, going to bring you in here. You may have touched on some of this before, but let's talk about what kind of scenarios you're seeing as you talk to other customers, potential customers. Some more of those challenges on the ground that people are coming to you and saying, can you help me with this, or here's my problem?
Absolutely. So, well, let me tell you, all of our clients, our prospects that we see out, they're all extremely busy right now. They're typically right in the middle of doing implementation, or they're starting a new implementation to an EMR. There are challenges around mergers and acquisitions. There's a lot of activity in the healthcare space right now, so we have a lot of our clients currently and prospects that are coming to us now to ask questions that are acquiring ambulatory sites, for example, and not just one or two, but 50 or 60 ambulatory sites as they're doing a lot of these acquisitions going on. And this is a huge market and a very big not necessarily a problem for them. I mean, it's exciting for them to have these acquisitions going on, but it is definitely, it makes it a little bit more challenging when they start talking about planning out how they want to bring those sites in, get them on their new EHR, and then bring those into an archive scenario. So those are some of the things that we're seeing a lot. They're bringing a lot of applications, some consolidation with the big vendors out there, the big healthcare sites out there. They're consolidating as well. We've seen more of that in the last 5 years. And so we tend to see clients bringing us from one application to several hundred applications that they need to do an archive with. And so as you can imagine, the planning time really needs to be taken into account when they're looking at getting these kinds of things rolled out. Those typically will phase out based on the phasing for the rollout of those the new EHR. And so when you're talking about planning for that, think about those kinds. Andy mentioned an inventory earlier. Getting your arms around that early is important, so you know what you've got in-house, whether you've got a centralized or a decentralized IT shop. You really need to know what the applications are out there, because your goal is to reduce your footprint overall. You're replacing many systems with your new EHR, which makes sense then, all those legacy systems, to replace them with one archive, so that you're really reducing the footprint, and those are all kinds of things you need to think about and that we're seeing clients really focus on right now.
All right, very good. We're going to go to my favorite feature. Andy, I know you're excited for this, our Ask a Co-Panelist feature. So I'm going to let Kel go first. Kel, what question do you have for these two fine gentlemen? And let's make sure we bring Jason in here.
Yep.
So I think I want to start with Jason. So Jason, from the perspective of being the Director of Application Services, I know that one of your roles there is to focus on the applications, get everything down to a minimum, and reduce that footprint that you guys actually have there. One of the pieces, not just from an electronic, but from the paper perspective, I know that there was, as Andy mentioned, 3 warehouses out there that you guys were doing, and so I would like for you guys maybe to kind of discuss a little bit or give an overview of how that process is going, reducing that footprint for them, because we do run across clients now that have questions about being able to do that. How long does it take? What is a good solution for it? Do they go outside? And what would you guys recommend for getting through that part of data?
Sure. Our HIM department is doing an excellent job, but it is a massive job, and so they approached it in a couple of ways. They target a certain number of boxes per period, and so that's one way they're handling it. But as they go through these boxes and they inventory them, they're making decisions on whether or not it meets record retention requirement time periods. And if so, at that point, they may scan it actually into our existing EHR system, since they're already touching the box at that point, versus doing it all in one big project. So we really, when we were looking at the ROI of, do we want to take all of the paper records from decades and doing that in a concerted effort, it was a major lift, a major time commitment. And it's a different animal than really trying to do electronic migration or archive or conversion when you're looking at the paper. These boxes had all kinds of categories. There was some organization to them, but some of them, you're surprised, they may have turned out to be moving boxes versus actual paper records. And so they may have things from offices that don't really convert into a system. So it's interesting as they go through these over time.
All right, very good. Andy, your thoughts?
Yeah, I would just add, Jason kind of concluded with the boxes. I think in the electronic world, we think of garbage in, garbage out a lot. Well, we had the paper version of that. We literally found dozens of boxes that just had somebody's desk that left the organization. They cleaned the desk out, put it in a box, and sent it to archive. So we had a lot of that to get rid of. But I think one of the keys to us being successful at that, I think, was we set up our retention policies, defined those before we started. So our first pass through our HIM department was just identifying boxes that had records that we knew were outside that retention policy. So I don't remember the exact count, but it was 60, 70,000 boxes when we started. And we were able to take, gosh, I think it was 15,000 or more boxes almost immediately, just because they fell clearly outside of our retention policy. So it made the first pass-through easy. And then, as we looked at it, trying to really deal with that question, how much of this do we want to scan into our archive versus just leaving in paper? And that's where we really got into the questions involving the clinicians and things. What for this type of record, this specialty, whatever, do you need access to this or not?
All right, very good. So here's what we're going to do now. Now we are going to let Jason ask Kel a question. Jason, you ask Kel a question, then Andy, it'll be your turn.
Okay, thanks. Kel, the emerging healthcare landscape and, in fact, the political landscape to share data in between care providers is really gaining a lot of attention. When a patient transitions care from one practice to another, there's really the emphasis on the receiving practice seeing the complete picture of care for the patient. How is MediQuant approaching the need to share archive data in this landscape? Do you have any APIs, FHIR APIs on the roadmap? What is the strategy with data archiving and the ability to share that across practices?
That's a great question, Jason. So with regards to FHIR, we have first quarter in 2020, we will be FHIR enabled to be able to share that data. Of course, it goes back to the patient giving permission to share that, or the owner of the records as well. It's not uncommon, and we are finding, as you mentioned, not only is there mergers and acquisition activity going on, but we do find where hospitals or clinics are separating as well from a hospital that they may have been affiliated with or had been acquired and they're purchased from someone else. So in cases like that right now, we have pulled the data out of one data arc instance and moved it to another if needed. And also one thing about the data product is it is a role-based system. So they can, if it's still within the same health network and you're simply moving one provider to the other, it's a matter of changing security permissions inside of the system. So we get different scenarios and we handle each one of them a little differently. We handle them as kind of one-offs because we're constantly, as you're saying, we're running across new scenarios all the time. And so we've with the FHIR enabling that's coming in to be able to work with maybe HIEs or other systems, as spinning up a new instance of DataArc, which is the product, as you guys know, and moving data if we need to a new environment. But we've loaded that information so that we can easily pull it out and move it if we need to. Let's say they're moving to a different facility. So we have done that in the past on projects, and we don't see that stopping. So we can move it when they're acquired one place and then move it out if they're no longer part of that organization. Does that answer your question, hopefully?
I think Jason's good. Andy,
okay.
Your turn to put Kel on the hot seat.
Okay. Well, I had several different questions, but one that you mentioned briefly that I wanted to get a little more of your thoughts on, Kel, is around the whole purge functionality feature. Once we have data into an archive electronically, our human nature is not to delete anything, and we hate to push that button to get rid of it. And I know we worked a little bit with you on the kind of pilot in that feature and things, and even we had those reservations about pushing that button. Just what are you seeing out there as you've developed that feature? How are people dealing with that purge and such as they try to meet their policies?
So that's funny you asked that question, Andy, because you guys did help us work on the development of that feature. It is available. So let me explain a little bit about the feature. It is an auto assist purge feature. So there's a dashboard that's built into the system. It requires 3 approvers to actually purge data, so that each individual client can enter their parameters, purge parameters in the system. So your retention requirements, for example, maybe transactions and patient accounting, you keep them for 10 years, and then you no longer need the transaction data. So you can build in retention parameters in the system, and then when for any account that meets that requirement, it'll bring all those up for you. You can review them. You can put things on legal hold, and they won't purge, that kind of thing. But it takes 3 people to approve the actual purge of the data. So you've got 3 approvers. In the dashboard tracks, once it's gone through 1, it goes to, it'll say waiting on second approver, et cetera. And then once you actually purge the data, it will leave a stub account in the system. You have record then, you have a certificate of destruction in the system, and you have a list of all the records that were purged during that process. So, and the system maintains the stub information of what was actually purged out. So you don't have the records, but you have proof that you've purged information. So to Andy's question, it's a great feature. We don't have any of our clients yet that have wanted to use it. I think one thing that is driving them is not necessarily, as I mentioned, there's kind of a conflict between what the clinicians or the researchers want to keep everything. Legal wants to purge it out of the system. So there's discussions with that. I think something else that's driving clients right now is just being able to potentially purge out data and reduce costs for hosting. So when we're hosting an application, let's say they came in with several terabytes of data and we're hosting that and they're paying storage for that amount of data. The biggest question we've gotten lately is if we set up our purge parameters and purge that data out, can we get a reduction in our hosting fee? And the answer is absolutely. So I think that may drive people to actually using the purge piece more than whether or not they're actually going to worry about, the argument between legal and your researchers, because we do just say, listen, for research, just, you can de-identify the data. We have a SQL copy of it for you anyway, move it out to another server, OpenArc, you can do all your research there if you want to, and then that way you can still use the purge feature. So to Andy, your point that it's there, it's a great feature. None of our clients, and we've got over 300 healthcare systems that we have, none of them are using it yet. They're all a little bit gun shy about actually using the feature.
That's funny. All right, we got an audience question I want to get to, and then we're probably going to be out of time. But this is an interesting question. I believe this was touched upon, and I certainly don't have a Juris Doctor. But my question is this: if a patient has a 50-page record, and because of a move to a new EHR, the record is 10 pages. From an outsider looking in, it feels like negligence to some degree. Again, a bit ignorant here. Would it be best to include our lawyers to provide any federal or state laws as it relates to health records and retention? Does this make sense? I'm going to go to you first, Andy.
Well, I don't have a law degree either, so from our standpoint, most everything we're bringing into the archive is all the data that was in that previous record. Jason may be able to give a little more details to how that comes in, but it's not. There's no data disappearing, if you will. The formats make a little bit of a difference, but Jason, I don't know if you have thoughts on that.
Sure, I can't speak from the legal aspect, but from the clinician aspect, we did loop them in on the decision-making process, and what they said, specifically talking about our conversion from Allscripts to Athena, was the general rule of thumb is they wanted 3 years worth of data at their fingertips, and so anything older than that was what was targeted to be in the archive to begin with. that was from a practicing medicine side. So I don't really have the legal practitioner by my side to really back up whether that's the appropriate way there, but it was really looked at from the standpoint of what do they need to care for the patient at that point in time, at that episode of care, and then the rest of the data was available in the archive to retrieve if they needed it for a more advanced look at the patient, more historical look, or for research purposes.
Yeah, and the one other thing I would add to that we did do, our legal compliance was involved in a lot of the policy making and the process and kind of verifying, validating that what we were doing was acceptable. So we were relying on their judgment.
Kel, it sounds like having the lawyer by your side is not the worst idea in the world, but what are your thoughts on the question?
No, I would absolutely agree. So having legal involved, HIM, compliance officer, they are absolutely part of the stakeholder list that we want to be involved in it. When you're talking about, let's say, 50 pages in Maserati System Meditech, and maybe those 50 pages get reduced to 10 based on the format or its printing, the point is that all of your content is there. And that's usually where we want legal to weigh in, but there's a stringent validation process. For example, we have 900 plus scripts that we run over the data before it ever makes it to the client, and then we do parallel testing, statistical validation. There's a lot of different validation points, and the client also does validation. So they are comparing content of what was in the legacy system to content that's in the legacy or the archive system in DataArc, and you really want to make sure that what you're seeing in one, you're seeing all of the components in the other. And so the audit modification, detail, history, preliminary results, versioning of documents, all of those things you want to make sure you've got in your archive so that you can respond to legal audits that when you or legal requests, that you're not just looking at from a legal medical record perspective that you're going to give a patient a copy of their record, but you need to be able to have all the pieces and parts that go with that, all of what we consider metadata, and all the pieces that legal would say, yes, we need all those date time stamps, we need all of those things in there, and we store those in the system. And I think any system, you want to make sure if you're going to shut down your legacy, you want to make sure you have everything to be able to respond to a legal audit sitting in your archive.
Kel, the questioner just sent in a note to provide transparency. It went from 50 to 10 because of a lack of conversion or lack of abstraction. Does that give you any more color? Yeah,
and I would worry a little bit about that. I mean, if you start out with 50 pages and you've abstracted something out, then I would worry about it because that means you're probably missing data. Yeah. In that case, if you don't have if you're looking at a result of something, let's say a radiology result or a whole patient record, and you see lab, radiology, MAR information, provider notes, flow sheet notes, and then you get it somewhere else and that's not there, then you definitely have a problem, and you don't even need to get legal involved, I think, at that point. I mean, I just think that, HIM is going to know that you're missing data. So that's part of your validation. You're looking to make sure all your pieces and parts are there.
Any final thoughts on that, Andy?
Yeah, I would agree. I think having, for us, two things, having the legal compliance, HIM all involved in the process so that they were comfortable with everything we were doing in that migration. But then also, I think it's time consuming, but that validation is key. You have to have the people that can validate that data doing so and being fairly meticulous in that so that you know that the data in the old is the same, that the old system that you're archiving is the same data, because formatting will be different, but is the data there?
Well, that's a perfect note to finish on. So, regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our webinars. So if you've let CHIME know you were here, great. If you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll get an email when the on-demand recording of this event has been posted to our site. If you want to sponsor an upcoming event or book a custom event, you can reach out to Nancy from our team, and you can go to our website to register for our upcoming webinars. So with that, I want to very much thank our excellent panel, Andy Goodwin, Jason Lovett, and Kel Pults. And I want to thank MediQuant very much for sponsoring this event and making this conversation possible. Of course, I want to thank you, our attendees, for coming to our events. But with that, everybody have a wonderful day. Thank you.